Okay, firing back up, Chapter 19, Diseases of the Eyes, Ears, Nose, and Throat. This is, to be honest with you, where I start to call it the grind. We have to get into some stuff that we just keep plugging through, and as long as you stick with me, you sit in your seat in the bus, I'm going to keep driving us there. So much of this, I'm trying to think of anything really, if there's much that has changed other than going more in depth. Of what you've already done, whether it would be an EMT class or advanced class, because there's really not much difference of diseases of the eyes, ears, nose, and throat. So real quick, honestly, probably the biggest bullet point we could talk about is when we see these last two, nose and throat, think airway. So, we need to be very thoughtful about the airway, but that's honestly going to be some of the biggest things for us because we don't typically treat long-term chronic things or, something like that. So let's get going though. So we're talking about calls of eyes, ears, nose, and throat type of problems. So this can involve disorders of the eyes, ears, nose, and throat. So a significant number of calls will involve trauma, as you can imagine. People getting, cut or stabbed or hit or assaulted, whatever. I mean, it's a lot of different things that can happen, but that's kind of what we're talking about. So familiar with these conditions will help you when you're assessing these patients. So it also allows you to educate the patient on prevention or even potential care when we're talking about these type of injuries or a disorder. So they need to be transported to an emergency department with access to an eye specialist or an ear, nose, and throat specialist. So if this is something that is serious that requires emergency treatment, then we need to make sure that we're getting them to the right place. As we always talk about, the right person to the right place. Oculomotor nerve, your third cranial nerve. I'm not going to ask you to put all of those to memory. You may have done something like that in A&P, and if you've had any type of biology class in college or something, then you probably have at one point had to. That's not that big of a deal with me, but there is a few to talk about. So the third nerve causes motion of the eyeballs and the upper eyelids. So the thing to think about, this nerve, it innervates the muscles that cause motion of the eyeballs and the upper lids. So it carries the parasympathetic nerve fibers, sympathetic nerve fibers that cause constriction of the pupil and accommodation of the lens. So knowing that, you can understand where this might, if there's damage to that nerve, we might see some pearl type changes when we're talking about constriction of the pupil and accommodation of the lens. Then moving on to the second cranial nerve, the optic nerve, it provides the sense of vision. So we're not going to go much into this. This is something you've already seen, something you've already been tested over. But patient assessment, as always, ensure scene safety. Keep your patient calm. Get you a good general impression. So note environmental clues at the scene. Note the approximate age and sex of the patient. Note the patient's degree of distress. It's always good to try to kind of figure out what amount of distress that they're in. And I'm a firm believer in documenting that. So, if you were to write in no apparent distress or, a patient appears to be in distress, then that gives whoever it is, the QA officer, the RN at the ER, the doc, or a lawyer, it shows, number one, that you addressed that you were looking to see if there was any distress, as well as it just kind of lets the people know what's going on. Assess airway and breathing. We're going to talk about that. It's probably going to be some of the biggest points that we talk about. So as always, with our primary assessment, our primary survey, we're going to rule out those life threats. So this is a place where it's really easy to get distracted by injuries that may not be life-threatening and are not, but it will take your attention. So when we start talking about trauma to the eyes and maybe even a globe that has been eyeball that is hanging outside of the eye cavity, of the skull, it's been popped out or something, that obviously can become very distracting. So don't allow yourself to become distracted with this stuff. It's important that we remember our primary survey and we're able to move on. Early transport. Early transport can improve outcomes because much of this is going to be time sensitive. So now remember, when you do have damage to one eye, we want to cover both eyes to limit damage to the affected eye through the sympathetic movement. So what happens is I can't remember the term. It's not sympathetic. May have been sympathetic. But what it is your one eye follows the other eye. So you cover up the injured eye, but the other eye is open, the unaffected eye, and it's looking around the back of the ambulance, looking at you as you explain things, and that other eye is following the same pattern as the unaffected eye, which is going to cause more and more damage. Obviously, we want to consider some pain management. Cardiac monitor is recommended. Here's why. Ocular pressure can stimulate the vagus nerve. That's why a lot of times when people have eye stuff done, they get people can get bradyed down. If you've ever been to the eye doctor, that's why. It can certainly cause them to have a vagal nervous issue. And then eye drops medications also cause some side effects such as low or high blood pressure as well. Still talking about patient assessment, obtain the chief complaint in the history. We want to use, obviously, our OPQRST if possible. So how and when did the symptoms begin? What symptoms are experienced? Are both eyes affected? Are there any underlying diseases of the conditions of the eye? A lot of different things that we can find out. Symptoms that may indicate a serious ocular condition include, so a few different things to think about, visual loss that does not improve when the patient blinks. You know, a lot of times our eyes are a little bit messed up and we blink a couple of times and it kind of squares them away. Double vision, severe eye pain, obvious foreign body sensation. So if you have something either that you can see that's in there or even not, it's just that sensation of it, that is may indicate a serious condition. And then we want to make sure that we perform a thorough exam. Obviously, we want to use standard precautions. No really even reason to talk about that. We should be treating everybody like they're sick, so that way when we run into one, we know we're prepared. And then obviously avoid aggravating the affected area. So if they have something stuck in their eye, don't go messing around with their eyeball. Assess, whoops, I skipped a slide. Pain assessment, assess for pain and tenderness. We want to assess for swelling, abnormal movement or loss of movement, sensation changes, circulatory changes, deformity, visual changes, obviously airway compromise, as we said. So talking about the orbital rim, when we're still talking about assessment, we want to look for that ecchymosis, swelling, lacerations, tenderness. Really, you could just throw it out as BTLS, right? Or, yeah, I just had a brain fart. What is it? Not BTLS. Yeah, it doesn't matter. You know what I'm talking about, hopefully, though. DCAP BTLS. There we go. So DCAP BTLS. Eyelids, some of the same stuff. Ecchymosis, swelling, laceration, abnormalities, and then foreign bodies when we start talking about the cornea. You want to assess these structures. So the conjunctivae or conjunctivae, redness, pus, inflammation, foreign bodies, you're going to see a lot of that. So we start talking about that pink eye and the conjunctiva. The globes, redness, abnormal pigmentation, looking for lacerations. The eye surface, so growths, kind of weird, but you certainly can see some in there. Discoloration, differences between the eyes. And then, of course, we also want to do a good pupillary assessment. So we're looking for pupils that are equal, round, reactive to light, right? So when assessing the ocular function test, we're looking for visual acuity, so accessibility to see large and small letters. This is typically not something that we do on the ambulance, but one thing to think about, because that's probably the first thing you thought was, this is stupid because I don't need to know about this, whatever, fill in the blank with the rest. But our scope of practice and what we're doing, our job is expanding a lot. So we're working in clinics, we're working on ICUs and ERs, even running teams in ERs. We're also working on cruise ships. There's a lot of different stuff. So you need to at least have the basic for a lot of this stuff. So we're going to cover it. So when you assess for the ocular function, you perform these tests. So we want to assess the ability to see large and small letters, and that's what we're talking about, the visual acuity, and test each eye separately, and then document those results. Peripheral vision, so test the ability to recognize an object entering the extremes of the visual field, and then ocular motility. So you check the ability to move the eyes in all directions. Now, many times if someone got, cracked in the head or they're having eye problems or whatever, you may already start doing some of this stuff. You may ask someone, are you able to read this? And we're not doing that test like you do at the eye doctor where you cover up one eye from 15 paces or whatever, but we are wanting to make sure that everything is working properly. And then still talking about motility, check for paralysis of the gaze or coordination between the movements of the two eyes. So we could be looking for that disconjugate gaze. You guys should remember that from your EMT class. So the patient may experience adverse effects if he or she uses more than one eye medication, or if they use too much. Ask the patient how he or she administered any med that he or she has used. So generally recommend to wait 5 minutes between the first and the second drops. Eye drops and lubricants can be applied by gently squeezing over the lower eyelid. So you would we're talking about eye drops, conjunctivitis, eye pain, glaucoma, eye surgery, herpes simplex, corneal abrasions. It can be just lubrication because people have tear production issues. So also, as I just said, we're talking about lubricants. So eye drops and lubricants, they can be applied by gently squeezing the lower eyelid to make a patch and then applying the medication, roll the eyes, yada, yada, yada. I'm not going to go too much into a lot of that stuff. So irrigation may be necessary. Use sterile water or isotonic saline. Those are the two fluids of choice. Flush from the inside corner to the outside, and it may take a lot of fluid to get things cleaned out well. But eye injuries should be seen in the ED. And then many eye injuries, they can be irreversible. So contact lenses. Only indication for removing contact lenses in the pre-hospital setting is a chemical burn in the eye. Now, you've got a couple of different types of contact lenses. You see them there. I'll let you read about those if you so choose to. Here's a way to remove the hard lens. Use a small suction cup. Moisten the end with a saline. A little bit more of that. Eye prosthesis. So if the eye doesn't respond to light, so if you've got one pupil that's working right and the other one that just does not move at all, if it doesn't move with the other eye as well, or it appears quite the same as the opposite eye, or it does not appear quite the same as the opposite eye, then you might consider that they've got a prosthetic eyeball in there. Obviously, it's something that you can easily ask, but if someone is unresponsive, then you're going to have to kind of do a little detective work and figure this out on your own. Ophthalmoscope, rarely used by the paramedics. This is not something that we're going to do. So conjunctiva becomes inflamed. When we're talking about conjunctivitis, it becomes inflamed, it becomes red. Usually starts from one eye and spreads to the other. It's extremely easy to spread it. It's very, very contagious. So sometimes that viral conjunctivitis can be associated with upper respiratory virus, and then bacterial conjunctivitis, as you can imagine, caused by bacterial infections. So both of these are highly contagious. You also have allergic conjunctivitis. It's caused by a trigger or irritating allergen, such as pollen, things like that. Chlorine in pools can start to do that. You can get a chemical conjunctivitis as well. And if conjunctivitis is due to a foreign body, the eye will begin to produce tears in an attempt to flush out the object. So assessment and management of this, not much to do, right? You're going to do just some general supportive care. Whatever they need, they're probably going to get from the ER. Hopefully, we're not going to get called for just some pink eye. But if you've been around an ambulance more than about 3 calls, you'll know that 2 out of those 3 calls did not require an ambulance in the first place, more than likely. So, there's a good chance you will run somebody with that. Inflammation of the eyelid, swollen bump or pustule. I'm just going to not try to say that word because I'm not sure how you pronounce it. So swollen bump or pustule on the external eyelid. And what happens is you get, you have that protective film, the oil glands and the oil ducts across the eye. Well, a lot of things can happen, and these ducts get clogged up and get blocked, and everything starts to swell up. And you can get a sty as well. These are commonly known as a sty, these two production things that you see here. This is You've seen this. If you've not ever had one, you've seen this on many people. So it's an infection of that oil gland. It produces a red tender lump in the eyelid or at the lid margin. Assessment, thorough assessment and transport. Patient will usually be asked to apply warm compresses for 5 to 10 minutes several times a day. They may get some antibiotics. That will be up to the ED, obviously. Glaucoma, groups of conditions that lead to increased intraocular pressure. So you see there you have a lot of different types of glaucoma. These all lead, though, all of them lead to increased intraocular pressure, and this is one of the leading causes of blindness. So obviously not a good thing. Open angle glaucoma, so the aqueous fluid drains too slowly, and you get that pressure built up within there. That's really the most common type. And then narrow angle glaucoma, also called angle closure, so the aqueous fluid does not drain properly due to the narrowing of the drainage channel. And secondary is as a result of conditions that damage the drainage channel in the eye. Glaucoma assessment, rule out trauma or physical injury, perform a general eye assessment, and then obviously when you get to the ER, they're going to get a full workup on their eyeballs and get everything checked out, and they'll be good to go. Central retinal artery occlusion. So the blood supply to the retina has been blocked, and it could be because of a clot or an embolus in the central retinal artery, or even one of its branches. So this can be an embolus from the carotid artery. It could be because of a valvular heart disease, anything from drug abuse, fat emboli, arterial spasm, a lot of different things, even oral contraceptive use. So one thing that can happen, it can cause partial blindness, which can be temporary or permanent. And the way that we're going to manage that assessment management, I don't think I have that yet, is when you have we're talking about sudden and painless loss of vision in one eye, then we need to cover eyes up and obviously get them to the doctor. Iritis, inflammation of the iris, or maybe iritis, I don't know. Acute causes, trauma, irritants. It's the third leading preventable cause of blindness. Can be acute or acute or chronic. Acute can be caused by trauma or irritants and usually affects only one eye. Chronic causes include autoimmune diseases, arthritis, irritable bowel disease, Crohn's disease. Infectious causes include Lyme disease and tuberculosis. Even some STDs can cause that. So iritis presents as a red area surrounding the iris, cloudy vision, or an unusually shaped pupil. So we're going to focus on the history. Usually this stuff responds well to corticosteroids and whatever else the ER may choose to do. Papilledema, swelling or inflammation of the optic nerve. So symptoms of this would be headaches, nausea with possible vomiting, temporary vision loss or narrowing vision fields, even a graying in the field of vision. So this can be caused by abscesses, tumors, inner ear infections, lung infection, dental infection. Can even, as you see on the other side, we got meningitis, fever, hypertensive crisis, even Guillain-Barré syndrome. Pre-hospital treatment, treat symptoms, transport, ABCs. Once again, everything's with this, other than unless there's airway involvement. For the most part, we're talking about general supportive care, ABCs, making people comfortable. Maybe if you have the protocols for it and they're hurting, maybe you could give them a little pain meds, be a nice guy. Cellulitis of the orbit, so paraorbital cellulitis and orbital cellulitis. So commonly caused by staph or strep infections. Usually the paraorbital is more prevalent in children than adults, also known as preseptal cellulitis or even eyelid cellulitis. Presents as a painful red swollen eyelid, fever, redness of the part of the white parts of the eyes. Predisposed factors, so we're looking at insect bites, upper respiratory disorders, even some trauma can be one, a predisposing factor. And then we move on to orbital cellulitis, so an infection within the eye socket, considered a medical emergency. Goal is to treat to avoid the formation of an abscess, but for us, how are we going to do that? So we're going to get them to the right person at the right time and all that fancy stuff. Treatment includes antibiotics. So, and and see some of these things, maybe one of these days you guys are going to become one of the community paramedics. Well, there's a lot of expanding scopes within the community paramedicine area to where they're doing antibiotics and a lot of these different things. So this, I understand right now, and as you're listening to this, because I'm boring you to death, but this is some of the stuff we need to pay attention to. Corneal abrasions, most common eye injury seen in the ED, so more times than not caused by trauma, foreign body, can be contact lenses or even exposure to ultraviolet radiation. Ulcer development without prompt treatment, and it can cause blindness if left untreated. So we talk about assessment and management. Symptoms: pain with extraocular movement, redness, tearing, sensation of having something in the eyes, blurred vision, photophobia, headache. Management: rule out life threats, take a thorough history, transport promptly. If there's a corneal abrasion, that's a good one to cover up as well, to cover up the eyes so we don't get movement in there and cause more and more problems, because there could be something in there. Many times you've probably already ran on people that were grinding metal or grinding something and they got a little shaving in their eye or something. So those are good times to get their eyes covered up and that way we're not causing more and more damage. Moving on to the ears. Tell you what, let's take a quick short break here, and then we'll go to the ears. Okay, the ears, picking up where we left off. Primary structure for hearing and balance. Once again, we're going to cover just a little bit on some of these things. Some we're just going to gloss over, and if anything, it'll be your responsibility to either have known it or to make sure that you do know it. But disorders and injuries can leave a person unable to communicate, obviously, react, maintain equilibrium. A lot of different things go on within the ears. Obviously, like if you've been into the mountains or you've been diving, those changes in that air pressure can affect the comfort in your ears. So the ears are pretty sensitive and delicate kind of structure. So divided in 3 anatomic parts: external, middle, and inner ear. Sound waves travel through the ear and internal ear structure from nerve impulses that travel to the brain via the auditory nerve. So the brain converts these impulses, though, into sound. So talking about scene safety and patient assessment and all of those things, when we're talking about a ear injury, nothing's going to change. We're going to observe the scene for hazards. We're also going to still look for age and sex of the patient, environmental conditions, degree of distress, some of those same things. Whereas before we were looked to see, if we were able to see any eye injuries or things like that. Now we're looking for presence of a hearing aid or something that might cause some problems for an ear. So foreign objects forced into the auditory canal can damage the eardrums, as you can imagine. Ear infections can also cause the eardrum to blister and bleed, and eventually can actually burst because of the pressure. And then, as you can imagine, a blast like the pressure wave can also do that to burst the eardrum as well. So, as always, ABCs, complete history. In the ears, we're going to look for some drainage, maybe inflammation, swelling, that type of stuff. Have the patient rate their pain. We're going to look for wounds, swelling, drainage. Battle signs is an important thing in the event that there was some kind of trauma. We're not going to use an otoscope. Typically, it's not something that we do in the back of an ambulance. Now, working in a clinic and working at in an ER and stuff like that, you might end up having to do that. And you might work for a place that has one of these, maybe in your kit or in the back of the truck. Impacted cerumen, yellowish oily substance found in the ear canal, so that's kind of yucky. If you've ever spent much time in the ER, you've probably been part of getting impacted, maybe is the right word, but an ear canal cleaned out of there, and use a number of things, peroxide and all these different things to get that stuff broke up, because if it's not, it'll actually just cause a big old compaction and impaction, and what happens is it puts a lot of pressure on the eardrum and becomes obviously very painful for the person. And it's pretty yucky to have to clean that out, as you can imagine. So don't be that person that has to have that done, because I can tell you from experience you are not a very well-liked person in the ER. So, risk factors: abnormal ear canal shape, diseases that caused increased cerumen. We're essentially talking about earwax, or improper use of cotton swabs. I think many people use those. We're told not to, but usually that's what I think the majority of us do, is use those to clean out your ears. You got to be careful to not poke one right through. That's not good. So, assessment management: pressure or fullness in the ears, ringing in the ears, loss of hearing, pain or itching. So, you're going to get you a good history. You're going to do a visual inspection of the ear, that type of stuff. It's important to understand that injuries or infections, if they are left untreated, can become a real problem. It can cause someone's complete loss of hearing. Labyrinthitis: feeling of vertigo or loss of balance after an ear infection or upper respiratory infection. So, most commonly recognized as the feeling of vertigo or loss of balance after an ear infection. And what happens, you get that infection in there, it starts putting pressure on your eardrum, and that causes the way that we sense things to be altered. Effect on the nerves of this inner ear and loss of balance from irritation and swelling. And then some other symptoms are ringing in the ears, dizziness, loss of hearing, nausea, vomiting. Once again, pre-hospital treatment is going to be, well, as you see, reduce nausea and vomiting. So maybe you might do some Zofran or something, maybe Phenergan if you're old school and have that. But you'd want to get probably an antiemetic if they were having some vomiting type issues. Meniere's disease, a chronic condition of the inner ear characterized by dizziness, described as spinning vertigo, low-frequency hearing loss, tinnitus, or the ringing of the ears, feeling of fullness in the affected ear. So what you get is you get an overproduction and defective absorption of endolymphatic fluid, which increases the volume and pressure within the labyrinth of the inner ear. So you get some distension that happens, and it ruptures and mixes the endolymph and the perilymph fluids. Well, that mixture disrupts the balance of fluid and electrolytes within the labyrinth and damages the vestibular and cochlear hair cells. So attacks of less than 2 hours in the early stages, altered balance up to 2 days. And then as the disease progresses, symptoms last hours to days. Pre-hospital care includes an antiemetic. So once again, anytime you're dealing with somebody with vertigo, you may need to, give them a little bit of Zofran or something similar to that. Infection resulting from bacterial growth, talking about otitis externa and media, so inner and outer ear infections. Signs and symptoms: edema, erythema, diminished hearing acuity, inflamed, bulging tympanic membrane. Many times with small children, you'll see them kind of tugging on their earlobes. If they've also probably going to be running a fever. If they're kind of snotty and don't look so pretty good and tugging on their ears, more than likely they've got some type of ear infection. Maybe with many other things. They could be sick with an ear infection. When we say sick versus not sick, but or it could just be simple that they have an ear infection. Moving on to the nose. We're getting there. We're down a couple of organs. We got 1 or 2 more to go. So susceptible to injury because of its prominence. Allergens, particles, chemicals cause inflammation. Inside of the nose is very vascular. That's why we're able to use it to give medicines, to give certain medication, intranasal, IN. So knowing that it is very vascular, that should cause you a little bit of concern when someone gets smashed in the face or something, that you could see a lot of blood, because the head by itself is very vascular, but then inside the nose is much more vascular than somewhere else. So you got some smelling disorders. I'm not going to go through these. You're welcome to read those. Anatomy and physiology review. There you go. So get on to patient assessment. Look for environmental clues. Ensure scene safety. Assess airway and breathing. Always determine the level of distress. And nasal cavities, as we said, can be very prone to bleeding. So we want to take care of that. So patient assessment, obviously the same stuff, looking for environmental clues. ensure scene safety, A, B's, and C's, level of distress. So if we're talking about a nasal injury, insert an airway adjunct as needed. Do not insert a nasopharyngeal airway or attempt nasotracheal intubation with suspected nasal fractures or CSF or blood leakage from the nose. Don't ever do that. You should know that from EMT class, but if you forgot it, please remember it. That is something, number one, that will fail you on any test, and B, it will could have the potential of really hurting somebody. So we don't want to do that. Nosebleed, obviously some trauma, dryness, hypertension, a lot of different things can cause nosebleeds. You know, one of the worst things you can do, you get a bad nosebleed, somebody gets a bad nosebleed, and then finally it shuts down, and then they blow their nose. And it blows that huge clot out, and then you're going through it again. After multiple episodes of this, people can actually lose enough blood that they have some issues, because some people can lose a lot of blood through this. So epistaxis, that's what we're talking about, a nosebleed. Anterior, bleed fairly slowly, and posterior, more severe. So anterior, self-limiting and resolve quickly, and then posterior often cause blood to drain into the throat, causing nausea and vomiting. And what we're talking about is two different types. So, you know, we used to always have people, we would hold our heads back, and then that's what it did is the blood would drain down into someone's tummy, and then of course it'd make you feel sick to your stomach because now you've got all that blood in there, as well as now it might come up. So things that we're doing now is, you know, a little bit different. You're having people push their head down forward. You can definitely place something, less pressure on the bridge of the nose, maybe a cool compress. But direct the patient not to sniff or blow his or her nose. So foreign body obstruction, obviously you're most likely going to be seen in pediatric patients. I've had one of my own kids put some type of one of those ginormous peanut M&Ms up into one of his nasal cavities, as well as some kind of mint. I don't know why they insist on doing that, but it happens. So just be aware of that. So pressure in the nasal passage can cause tissue necrosis. Now, typically the nose is going to be creating a lot of just moisture. I don't know if snot. Let's just call it some snot, and it's going to lubricate that thing, and hopefully you're going to be able to get it out of there by putting pressure on it as well as having them blow behind it. But it can definitely cause necrosis if it's in there for very long. Inflammation, swelling, you know, it makes sense that all of that can happen. Tissue ulceration, epistaxis, and nasal blockage can lead to sinusitis. So you get everything trapped in there and causes a little infection. So first thing we're going to do is determine if this condition is life-threatening. So once again, going back to our sick versus not sick kind of thing. Any persistent, foul-smelling, purulent discharge should lead to suspicion. So just by reading that made me feel kind of nasty. So essentially this, if whenever something happens, if you feel kind of nasty, that ought to give you some suspicion that maybe we got a bacterial issue or something a little more serious is going on. Rhinitis, inflammation of the nasal cavity. So it can be caused by a number of different things. Caused by bacterial or viral, allergens, infections, allergens, meds, changes, environmental, temperatures, can be caused by certain medications as well as foreign bodies, irritants in the air, and hormonal changes in pregnancy. Assessment and treatment, nasal congestion, sneezing, we're talking about signs and symptoms, post-nasal drip, all of that. Keep the patient in a Fowler's position. So just allow the stuff to drain, you know, just allow the stuff to drain and get out of there. That way nothing gets down into somebody's airway. Variety of symptoms when we're talking about sinusitis, so inflammation or sinus infection. Facial pressure, pain, sore throat, very common, especially in Oklahoma with all the way our allergies is. Condition can be chronic, acute, recurrent. Not much we're going to do for people. Moving on to the throat. So disorders of the pharynx and larynx may include inflammation, infections, or abnormal growths. Throat infections are common in children, so they can be exacerbated by swallowing problems. There's multiple nerves, multiple cranial nerves that are involved in, or not involved, but all play a role in swallowing. And just in case you were keeping track of them, you got 6, you got 7, 9, and 11. They all play a role in swallowing. So if you had a neurological issue with these cranial nerves or some type of trauma to them, obviously you could have a swallowing issue. The downside about that, the really big problem with that, is the kind of things that you see over like in the nursing homes, is a person that's having issues maintaining their own airway and swallowing is also going to have some aspiration potential. So aspiration pneumonia is something that's really bad and can kill somebody. So esophageal disorders, they can affect the throat. So the valve, you have the valve at the back of at the end of the esophagus. It keeps acidic stomach contents from coming back up the throat, which is a good thing to do. In esophageal reflux, the valve only partially closes, or it even opens up too much. So some of those symptoms include burning sensation in the chest, indigestion, even a change in voice tone because of the damage that it can cause. And it can cause a precancerous condition as well. Patient assessment. Swallowing abnormalities require a position to allow drainage, lateral recumbent or recovery position. So assessing stroke patients must include early recognition of airway threats. Patients who cannot protect their own airways and are at risk for aspiration into the lungs, intubation should be considered. So, if we're thinking that they're unable to protect their own airway and there's a chance that they're going to aspirate, if you have the ability to intubate, then we probably should do that. So in your assessments, consider epiglottitis if there's symptoms of sore throat, drooling, forward hanging head, dentalgia and dental abscesses. So we're talking about toothaches and all of that kind of stuff, bacterial infections. Infection may become systemic. So, this is something that can actually cause some problems that we could see later down the line. But for the most part, you're going to see fever, chills, nausea, vomiting, all of those kind of things. For us, the most thing we're going to do is what you see down here, relieving symptoms. Diseases of the oral soft tissue, so it can be root cause of other problems. Gum disease has been linked to heart disease, stroke, diabetes, and osteoporosis. Some common mouth disorders, cold sores, canker sores, all that kind of stuff. I'm not going to get into all this stuff. Here comes a really nasty one. Whoa! So you got thrush here, which if you've had any small children, you may or may not have seen this. This one is not a small child when you look at these choppers here, because that doesn't look like a small child's teeth. But what they do is they get a fungus, that candida, that accumulates on the lining of the mouth. So it has to be treated, and it's just pretty yucky looking at it, obviously. But it's most likely found in babies, patients with compromised immune systems, patients who wear dentures, and then patients who used inhaled corticosteroids. Additional symptoms include pain, cracking and redness at the corners of the mouth, loss of taste, cottony feeling in the mouth. Patients are at increased risk include those with HIV and AIDS, cancer, diabetes, vaginal yeast infections. So really all we're going to do, make the patient comfortable if we're able to. Hopefully we're not going to haul somebody that calls for thrush. But you never know. So Ludwig angina is a type of cellulitis caused by bacteria from an infected tooth root or a mouth injury. About as far as we're going to go with that. I'll let you guys read about that. Epiglottitis, we're going to cover this in much greater depth and everything when we get to pediatrics, but it is an inflammation of the epiglottis, blocks the trachea and obstructs the airway. It's important to understand how serious this is, because this is something that can kill somebody when we're talking about little kids. So symptoms include fever, sore throat, painful swallowing, stridor, respiratory distress. The patient will look sick and anxious. Patient will sit upright in the classic tripod positioning or in the sniffing position. Patient may be drooling. Work of breathing is increased. So, there's a lot of things that can go on that we need to make sure that we need to be able to recognize and take them to the right place and at the right time. So you see this, do not attempt to look in the mouth, do not agitate the patient. Both of those are very important. I've never had one of these patients, or at least that had a compromised airway that ended up crashing or something. My understanding, though, is they have an airway that is extremely hyperreactive, and it will just shut down on you. So we don't want to get in there and mess around with stuff and all of that. If you suspect epiglottitis, make a little note of that and move on. Laryngitis, swelling and inflammation of the larynx. Fever, hoarseness, swollen lymph nodes, glands. Tracheitis, bacterial infection of the trachea. Tonsillitis, once again, tonsil inflammation and swelling of the tonsils, usually caused by viral infections. Pharyngitis, inflammation of the pharynx. You're kind of probably picking up a pattern here, aren't you? We're just naming off all the structures and throwing on the word itis. That's kind of what it seems like. So anyways, paratonsillar abscess. We get into all these nasty things. Collection of infected material around the tonsils. So complication of tonsillitis. Paratonsillar abscess, one or both tonsils are infected. Symptoms include difficulty and pain opening the mouth, facial swelling, inability to swallow. They want to give them some antibiotics and all that stuff. TMJ, some of you guys might deal with that. I don't know, but it's once again, hopefully not anything we're going to get called on the ambulance for. But arthritis, damage to the joints cartilage, jaw injury could have been a cause. Jaw muscle fatigue from grinding or clenching of the teeth. And it just makes it really uncomfortable for people, as well as gives them jaw pain, headache, difficulty chewing. The main thing is that locking of the joint, and it makes it really hard for someone to chew and to kind of just manipulate or maneuver their airway the way that they want. So that is it, folks. Chapter 19, diseases of the eyes, ears, nose, and throat. I apologize. It's nothing too exciting, nothing sexy about this, but is one more done. So we will see you guys soon, and be good.